Hello, I'm Dr. Diane MacIntosh. I'm a psychiatrist and the co-founder of SwitchRx. This is a SwitchRx practical review of Daridorexant. Daridorexant is an insomnia treatment sold under the trade name Quviviq in Canada, the US, and other international jurisdictions. It's indicated for the management of adult patients with insomnia that's characterized by difficulty with falling asleep and sleep maintenance. Daridorexant is a DORA, which stands for dual orexin receptor antagonist. As a class, DORAs have been commercially available since 2014, so they're not new. They're also not your typical sedatives. They have a novel mechanism of action, which offers some important advantages over older sedative hypnotic treatments. Because of this novel mechanism, I'll take a moment to explain how they work. Orexin receptors are widely expressed in the brain, but orexin-producing neurons are located in a small area of the hippocampus, where they promote wakefulness and arousal. They're inactive during REM and non-REM sleep. At night, orexin activity promotes wakefulness, and that can result in insomnia. Inhibition of orexin receptors is believed to decrease the wake drive, which facilitates sleep onset and maintenance, but daridorexant does not interfere with the ability to awaken to external stimuli. We tend to think about insomnia treatment from the perspective of increasing sedation or prescribing medication that makes our patients more sleepy. However, we should think about insomnia differently. Essentially, the brain's wake switch is turned on at night, leaving an individual too wakeful or aroused. DORAs work by turning off that wake switch, reducing wakefulness or arousal. Benzodiazepines, or Z drugs, are broad CNS sedatives that can reduce orexin activity. However, they can also lead to daytime impairment because their sedative effects can intrude into daytime hours. Before starting daridorexant, it's important to ensure your patient knows and is doing their very best to implement sleep hygiene. While it's hard work and sometimes inaccessible, cognitive behavioral therapy for insomnia, or CBTI, has demonstrated efficacy as a first-line treatment choice for insomnia. It's important to set appropriate expectations when starting a DORA, especially for those who are currently or have previously been prescribed older insomnia treatments. Your patient should not expect immediate sedative effects because of the unique mechanism of action I just described. Dose timing is really important. Advise your patient to take their dose 30 minutes before bed to allow sleep to occur naturally rather than expecting the feeling of being knocked out, which they may recall from taking an older sedative treatment. While studies show that some aspects of sleep improve right away, the full benefit increases over time, so it's important to allow 4 weeks before determining whether a patient has responded to the treatment. The daridorexant dose for adults with insomnia is 50 milligrams taken 30 minutes before bedtime. Only the 50 milligram tablet is available in Canada, which is the Health Canada approved dose. It should be taken with at least 7 hours remaining before planned awakening. No dose adjustment is required for patients over the age of 65, and it's not indicated for children under the age of 18. Daridorexant may be taken with or without food. However, sleep onset may be delayed if it's taken with or soon after a large meal. It's contraindicated with patients who have narcolepsy. This slide shows the typical cross taper, but it's important to consider that switching from a Z drug or benzodiazepine, especially from a high dose, may take many months. SwitchRx is based both in science and clinical experience, which suggests that initiating a taper of an older agent should not begin any earlier than 2 to 3 weeks after starting daridorexant, sometimes even longer. If a patient is finding it too difficult to taper from an older drug due to significant reemergence of insomnia, slow the tapering schedule and ensure that any comorbid conditions such as anxiety or depression are adequately treated. Daridorexant was developed to have a short Tmax, which provides a rapid onset of effect. It has an expected duration of about 8 hours, and a rapid decline in plasma concentrations after reaching its peak to minimize next morning residual effects. Daridorexant is a potent and selective DORA with equipotent binding of both Orexin 1 and Orexin 2 receptors, and none of its major metabolites contribute to its clinical effect. Daridorexant is extensively metabolized by CYP3A4. Its product monograph suggests avoiding co-administration with a strong CYP3A4 inhibitor, and to dose no higher than 25 milligrams if your patient is taking a moderate inhibitor because it can increase exposure to Daridorexant. Co-administering Daridorexant with a strong or moderate CYP3A4 inducer will reduce Daridorexant exposure significantly, so a higher dose might be required. There are a number of potential benefits associated with the use of DORAs for insomnia treatment versus older sedative hypnotic treatments. Daridorexant increases both REM and non-REM sleep without altering the normal proportion of sleep stages. It's not been found to cause rebound insomnia following treatment discontinuation, and there's no evidence of abuse or addiction or withdrawal effects following discontinuation. Safety data for the elderly is favorable. Older patients are not at increased risk of adverse events or residual effects the next morning after a nighttime dose of Daridorexant, even at 50 milligrams. Additionally, there is a lower risk of falls associated with Daridorexant compared to older sedative hypnotics such as Z drugs, benzodiazepines, or trazodone. And following bedtime administration, Daridorexant preserved the ability to respond to external noise stimuli, so study subjects were able to operate safely during the night. In general, most Daridorexant side effects are mild in severity and not dose dependent. The most common side effects reported in clinical trials are headache, somnolence, fatigue, and dizziness. At 4 times the recommended dose, 200 milligrams, Daridorexant did not prolong QTC interval. There are some rare side effects that can be associated with other treatments for insomnia. According to the product monograph, sleep paralysis was reported in 0.5% and 0.3% of patients receiving Daridorexant 25 or 50 milligrams respectively, compared to no reports from placebo. Hypnagogic and hypnopompic hallucinations were reported in 0.6% of patients receiving Daridorexant 25 milligrams, compared to no cases with the 50 milligram dose or placebo. Complex sleep behaviors such as sleep driving, preparing and eating food, making phone calls, or having sex with amnesia for the event have been reported in association with the use of other hypnotics. Any hypnotics should be discontinued if complex sleep behaviors are reported. The Daridorexant dose should be reduced for patients with moderate hepatic impairment, but dose adjustment is not required for renal failure, regardless of its severity. Please check out the Daridorexant drug information page for more details. The page can be found by clicking the drug name on the upper right-hand corner of the switch page. Rick and I are truly grateful you've chosen to use SwitchRx. Please check out our books or my website, podcast, or CME programs. Thank you so much for listening.